Sim, Alexandre, muito good morning. It's a real pleasure to be here at INCOR, at the room number 3, the brand new CAT lab of Philips equipment. To do a live case transmission for GI2. And first of all, thank you, Fausto, Carlos Pedra, the opportunity of INCOR to take part of this important meeting. We have here a live case for discussion. We are going to use the Inspire, the first Brazilian DES. We have here in the CAT lab with me Dr. Pedro Horta. Today is not very happy because your soccer team in Rio, Flamengo, was defeated by the Libertadores da América. And you have Fábio Pinton from São Paulo, our resident, and Carlos Vinícius from Salvador. As well, we have Cleonice and Rafael here to take care of this case. I'm going to ask Dr. Paulo Soares, it's our clinician, to show us the clinical case of this patient. Please, Paulo.
Good morning, everybody. Are you listening to me? Okay. The first case is a 72-year-old male, and he has hypertension, no insulin, diabetes, and hypercholesterolemia. No other comorbidities. And in January 2002, he was admitted to another hospital, and he was diagnosed with myocardial infarction. He had a conservative treatment at the Index Hospital and was discharged and referred to INCOR for an elective cath. And he is now with a stable angina, CCS3, and is taking losartan, aspirin, nitrate, glibenclamide, metformin, and statin. Well, his angiogram that was performed here in INCOR showed that has no lesion in left main artery and circumflex, and a very tight lesion in LAD and diagonal branch, a true bifurcation, which is going to be treated today. And here another view of this lesion. Another view, the spider, and mild lesions on right coronary. His left ventricular function has a mild to moderate dysfunction. Okay, his analysis showed a normal renal function, and that's all. So I'm gonna move to Expedito to start the case.
Yeah,
thank you.
Paulo, tell us about the clinical adjunct therapy for this patient before the procedure.
He's on aspirin, and yesterday he took 600 milligrams of clopidogrel, and that's and statin and other medications that he was taking already.
Okay, thank you very much.
You're
Alex,
welcome.
Did you see the slide of angio? Then now I'm going to show you and the panelists the injection that you performed today early morning. Please, Fábio.
From here,
Expedito. Good morning.
Oi, hello. Good morning.
We didn't see the spider view of the lesion. Could you show us again the spider view of that lesion, or any other view of that particular bifurcation lesion?
Yeah, we have all the angiogram in all vision. It's no left main, no disease, and the osteo, the circumflex as well, the osteo LAD. This is the best view that you choose is RAO, almost AP, for 10 to cranial 40. And do you have another injection in LAO? No. We did just this injection here, but the angiogram absolutely clear, no disease in another territory. Then our target to treat the true bifurcation, the LAD and diagonal.
Thank you.
So, Alex, then we have this true bifurcation. I'd like to hear the comments of the panelists about how the best strategy to treat this patient.
Let's start with Steve Bailey. Do you think you can get away with provisional in this case, where there's a lot of disease? How do you classify that? 111? I think it's 111 because there is disease proximal, right?
Yeah. So this is a more complex lesion with 111. The diagonal's not much smaller than the LAD as it continues as well. So you certainly are going to be more careful with that lesion than you might with others. I think that a provisional strategy always is a great strategy, but looking at the length of that lesion, the angle of the takeoff, I think that you're probably going to end up needing to treat that in order to stabilize that. So although I would do it provisional, I would recognize I'm going to probably convert pretty quickly to a bifurcated approach.
Miguel, one stent, two stents. Just a few more comments, Expedito, and then I get back to you.
Eu acho que não, acho que provavelmente vão ser 2 stents, porque a diagonal é bastante grande o ramo e a lesão aliada também é longa. Provavelmente vão ser 2 stents.
Any other different comment, Claudia?
I will go with 2 stents.
2 stents. Yeah. There's a lot of disease in the diagonal.
But
Very long disease in the
Yeah,
diagonal.
but you're going to have long stents in those, or maybe even 2 in the LAD by the time you're done as well.
Probably.
Eberhard, any dedicated stent for this particular case,
Oh,
or
yeah, this would be, well, basically, you know, the type of lesion that you, you know, the diagonal takeoff would be good for example, for the access stent, the biosensors access stent, the old DVAX would be great. It's a bifurcation stent, even for Capella and also for Triton. So I think this would be perfect. And then I would also go with 2 stents actually, at least plan.
for me? Yes. In Stanford, you only have.
Yeah,
the
we
FDA
don't have
approved
such a
stent.
dedicated stent. Just we must use just normal stents. At first, maybe just protect the side
Fumi,
branch and
you
do
have
the.
to bring this stuff over.
Yeah. That's good point. Yes. But
In China, there is any dedicated stent approved, Shubo?
We don't have dedicated bifurcating stent. We use 2 stents.
2 stents. Wonderful. Marden, you agree 2 stents, right? And Ricardo?
2 stents.
Okay, so there is a consensus here, Expedito, that it's going to be probably very hard for you to get away with provision in this case.
I like very much to. I'm very happy to hear all the comments in the special of Eberhard. Then I can hear his voice. It's he's recovering from the flu that they had on Wednesday. So the idea here is to work in 2 stents because as everybody said, the diagonal, the lesion of the diagonal is very long. So we did before go live pre-dilatation with 2.5 balloon in the LAD and 2.0 in diagonal. Move ahead, please. We use the apex balloon. We are using 2 BMW wires from Abbott. Then pre-dilatation of 2.5 and LAD. Generous pre-dilatation because the lesion is very long, and 2.520. And the diagonal 2.020. This you have a important section on the LAD. Then you can see, and we decide to go more. Then unfortunately we lost some diagonal branch after this generous pre-dilatation. So I'd like to hear now, Alex. How about we are decide to use 2 stents? I'd like to hear the comments of the panel. We have important guys, a lot of experience from China, from Stanford, and Miguel Hatt is one of the master of interventional cardiology in Brazil. We have here Dr. Pedro Horta. It's Miguel Pedro Horta. It belongs to the generation of Dr. Arié. They are responsible through training a lot of interventional cardiologists around Brazil and South America. And I'd like to hear the comments of the people here.
So let's start with Miguel. Miguel, now we decided that it's going to be 2 stents, right? There is a consensus here. What's the best technique? You do mini crush, you do V in this case, or perhaps TAPI. What would be your technique for 2 stents?
First of all, thank you for your comments. Very nice. I think I stay with 2 stents. You see, beside the dissection, the LED, you have a proximal LED not too large to accommodate 2 stents at the same time. I think mini crush must do the job.
Okay, for Miguel, it's going to be mini crush. Now from right to left here, Claudia.
I would do mini crush, and probably you have to put another stent in the distal part of the LED after the mini crush. I don't know the size of the inspiron that he is supposed to use.
It's a good point, Claudia. Thank you for your comments.
Good morning, Speedy.
Yeah, we have 38 Spiral 3.0.
There is a long version already.
Yeah, okay.
Yeah.
That's very nice.
So Martin.
I think mini crush is the best in my opinion too.
Ricardo, you agree? Mini crush also. Mini crush. And Steve, any different comment of Cesar?
No, I think that you could. Yeah, I mean, since everybody is doing that, I think that the concern is the mini crush does have seemingly a higher occlusion rate. So one could argue that this is one in where following the DVAX approach, where you could probably co-locate the skins and just deploy them together and not crush, leave them together. But the vessel size is small. I don't think you can really do that. So probably end up mini crush being the optimal.
Cesar. Okay, Eva. So before let me just ask something. Before we get to the real two stent technique here, Expedito, it would be nice for the audience to hear when you have a bifurcation like that. And again, it's kind of obvious that you're going to need to use 2 stents. What kind of guiding catheter you use? You go for 7 French. You think that 6 French does the job? Do you need perhaps a little bit of extra support with your